Good morning, everyone. Um, I recognize some of the names on this call, but not everyone. My name is Aimee Hildenbrand. I'm a research scientist and a pediatric psychologist here in the Delaware Valley. I work in the Center for Healthcare Delivery Science, and I'm really pleased to be able to share some of my work focused on um, developing and evaluating shared decision-making intervention for adolescents and young adults with sickle cell disease. Can someone just come off mute and say if the slides are showing the way they should?
I see everything and I can hear everything.
Okay, perfect.
Okay.
Thank you.
Mhm.
So a lot of my work over the last decade or so is really focused on adolescents and young adults with sickle cell disease as a special population. And I hope to convince you all today that there's something in sickle cell disease that perhaps others might want to join me in collaborating on work around, and also lessons that we can learn and apply to other chronic illness groups as well. Um, so I know some of the folks on this call may already be well aware, but just in case sickle cell disease is a new area of work for others, it's a group of genetic disorders. It's the most prevalent rare genetic disorder affecting Black and Latino individuals in the United States. And in sickle cell disease, our normal red blood cells, which tend to be squishy and round and flexible and able to slip and slide and squeeze through blood vessels throughout the body, become rigid, dehydrated, and sickle-shaped, as you can see pictured there. This causes complications, including chronic anemia, recurrent painful episodes, things like stroke, as well as chronic injury to heart, lungs, kidneys, bones, spleens, and many other parts of the body. Life expectancy has improved significantly over the past several decades, although it's still shortened relative to the general population at about 54 years. And in the United States, as I mentioned previously, sickle cell disease primarily affects people of African and Hispanic or Latino descent. um, Adolescence and young adulthood is a phase of life that's marked by lots of change and growth in education, in work, in social and family relationships, in emotional functioning. And adolescents and young adults with sickle cell face all of these normal transitions, in addition to the challenges of becoming more independent in managing their disease and moving from pediatric to adult healthcare systems. So as a result, it's not that surprising that during this tumultuous period, where there's lots of upheaval in healthy, typically developing people's lives, that we also see increased risk for disease complications and premature death in people with sickle cell disease. There are multiple disease-modifying therapies that are available to help reduce disease complications in this population. But unfortunately, many of the patients with sickle cell disease don't reap the benefits of these therapies. In particular, hydroxyurea is the gold standard disease-modifying therapy, and it's been around for decades. It has strong evidence of safety and efficacy, and yet we know that uptake of this medication is pretty suboptimal, particularly amongst our adolescents and young adults. So a lot of my work early on was to better understand what the barriers were to adolescents and young adults initiating and successfully staying on hydroxyurea. And a lot of our work showed that the barriers are pretty complex and that they occur at every level of the system. So we know that adolescents and young adults report that they don't feel very involved in decisions around their care, and certainly decisions around starting or staying on hydroxyurea, that they report having inadequate knowledge both about their own disease and treatment options, and they have serious doubts about efficacy and safety of medication options. We also know that providers might not offer disease-modifying therapies because they have concerns about whether patients can be adherent to these treatments, and that there are broader cultural and socioeconomic barriers of care that further intensify these obstacles. So as you can see here, uptake of hydroxyurea, as well as some of the other disease-modifying therapies, remains lower than we would hope in pediatric sickle cell disease. Shared decision-making is an approach that's been proposed to address many of these types of barriers when they arise with regards to uptake and use of effective therapies. Excuse me, I'm coming off of being sick earlier this week, so you might hear that in my voice. So there's a robust body of evidence that shows that shared decision-making interventions not only enhance patient knowledge, their engagement in their care and their satisfaction with their care, but also downstream effects like adherence to the selected treatment option and health outcomes. And we also know from newer research that shared decision-making is particularly beneficial for marginalized communities who experience increased difficulties with being part of the decision-making around their care, given kind of inherent power differentials within our health system. Shared decision-making is really a collaborative process where patients and family members and the clinician come together to make a decision about the patient's care that's aligned not only with scientific evidence, but also takes into account patient and family values, preferences, and treatment goals. However, we know from decades of work that shared decision-making is very difficult to achieve in standard routine clinical care. And there really aren't any interventions that are targeted towards the unique needs of adolescents and young adults with sickle cell disease. And this is in spite of, best practice guidelines saying that we should be doing shared decision-making in sickle cell disease and that patients and families prefer this approach. So the mission of my research program has really been to try to address this need by developing models that help to reinvent the way that we think about how to educate, engage, and partner with adolescents and young adults with decisions about their care. And so I'm going to just briefly go over some formative studies that our group conducted to understand decision needs and supports in this population, and then get to the meat of the presentation, which is really the intervention that we developed. So when we did intensive interviewing and surveying of adolescents and young adults with sickle cell disease. And essentially what we found was that when they are learning about disease-modifying therapies for their sickle cell disease, they want to talk about their options with a trusted healthcare provider. They want to receive education that's spread over multiple visits. In other words, they want to have time to think about a decision. They want to be actively invited and explicitly acknowledged as part of the decision-making process. They want to explore or have the opportunity to explore how a treatment might align with their broader values, preferences, and goals. And really importantly, they want to hear from other adolescents and young adults who have firsthand experience with that treatment. We also did a national crowdsourcing study to understand what healthcare providers who care for children and adults with sickle cell disease need in order to optimize the way that they're able to use shared decision-making in clinical care. And they said that there were really 5 things that are needed to optimize shared decision-making in this context, and that includes better high-quality patient education materials, billing and reimbursement models that help to incentivize shared decision-making, because we know that time tends to be a primary concern of providers, and having enough time to do shared decision-making well will require rethinking the way that we schedule clinic visits, for example. Providers also mentioned that they needed well-staffed multidisciplinary teams because although prescribers may be kind of the primary people having these conversations with patients and families, we also know that many other members of the team play a role in supporting and working with families, either when they're beginning a treatment or in terms of staying on a treatment successfully over time. Providers also talked about, the very pressing social determinants of health barriers that are prevalent in this population, and really needing additional resources to address some of the issues around things like inadequate insurance coverage, transportation barriers to clinic, et cetera. And similarly to patients, they mentioned that peer mentoring or peer support programs that allow patients to connect to others with lived experience be really beneficial. So taking what we learned from some of those early studies, we assembled a diverse team of individuals who have lived experience, so adolescents and young adults with sickle cell disease and their caregivers, as well as multidisciplinary providers who care for people with sickle cell disease, patient education specialists, health technology developers, and leaders in community-based organizations that serve people with sickle cell disease. And we got to work developing a shared decision-making toolkit to try to address as many of these barriers as possible. And as you can see in this flowchart here, our team met regularly and engaged in a series of intensive half-day co-design workshops to build a prototype of a toolkit, and to also think through a draft kind of implementation plan for how to use and disseminate these tools in clinical care. We then did formal usability testing to ensure that the tools were usable and acceptable to patients and healthcare providers. Um, and then we made real-time modifications as we were receiving feedback to improve clarity, interactivity, kind of portability of the toolkit until we had a refined version of the intervention. So we named our intervention the the shared decision-making toolkit for adolescents and young adults. The toolkit has three primary components. The first is patient education and decision aids that leverage advanced learning technologies to enhance adolescent and young adult engagement in their care and health literacy. Much of our patient-facing education is already publicly available. If you scan that QR code, it takes you to a Kids Health website that we developed in partnership with our diverse team that I mentioned earlier. This does not include our virtual reality health education programming that we're using in our clinic, because that requires a VR headset to deliver, but otherwise it includes articles, animations, videos, and other resources for patients and families who want to learn more about disease-modifying therapies. The second component is clinician training in core shared decision-making skills and tools that can be used to support clinicians in doing shared decision-making at point of care. So for example, we have pictured here in the bottom right, we have a communication support tool that's used in clinic that kind of elicits specific questions that patients and families might have about a disease-modifying therapy. So we know that oftentimes, you'll ask a patient or family, like, what do you think about this option that I'm recommending? And oftentimes you're met with like blank stares, or there's crickets, and there's not really, it's really difficult to think about important questions in the moment. And so both patients and families and providers spoke about this phenomenon. So we developed this tool to kind of facilitate more meaningful and productive conversations between patients and families. So our clinicians pull this out and they say, there can be lots of questions that come up when you're thinking about starting this treatment. Here are the ones that other families have that we hear most commonly. Which one do you want to start with? So it kind of provides them with the language that they can use to have a productive conversation about a treatment option that a provider is recommending. And then finally, we offer implementation support. So we have worked with our clinical teams to develop reliable methods of integrating these tools into the clinical workflow, with the goal of trying to educate and offer therapies using shared decision-making to all of our eligible patients. So after establishing high usability and acceptability, we launched a pilot trial to really evaluate feasibility of using these tools as part of clinical care. We're conducting the pilot trial in 2 sickle cell clinics within the Nemours enterprise, in our Wilmington clinic and in our Jacksonville clinic. Adolescents and young adults, ages 15 to 25 are who are considered candidates for one or more disease-modifying therapy by their sickle cell healthcare team are eligible to participate in the trial. Essentially, what happens is during weekly clinical rounds, healthcare providers will identify the patients who they plan to talk about one or more of these medications with. We approach these adolescents and young adults in clinic to offer them the opportunity to participate in this study. They complete some questionnaires prior to seeing their provider, and they have access to some of the patient education and decision aid tools before their provider enters the room. Then they use some of the communication support tools with their provider during the visit, and then afterwards they complete some additional questionnaires, and then we follow them for 6 months after the clinic visit to do brief monthly adherence assessments. We're also obtaining some information from the electronic health record about their use of the treatment options and acute care utilization. This trial is ongoing. We've enrolled about a third of our total sample, so we hope to enroll 60, and we've enrolled 22 adolescents and young adults thus far. We have a 64% recruitment rate, which is pretty great for trials in sickle cell disease. And importantly, 100% of our enrolled participants have completed pre and post visit data collection, and 83% of our participants have completed all of their monthly follow-up surveys, which is something that is really difficult to achieve with adolescents, young adults, given just the time of upheaval and the difficulty with tracking them for over a course of time. So we're really pleased that we've been able to retain this group. And you can see some of the demographics of the sample and just some information about, how long they're using some of these tools in clinic. So on average, they're looking at educational tools for about 10 minutes before their provider walks in the room, and they're spending on average somewhere between 30 and 45 minutes with their provider. This is some very early findings because, as I said, the trial is ongoing. But thus far, patients are reporting really high satisfaction with the toolkit. Most adolescents, young adults are agreeing that the information is really easy to understand, that the resources plus talking with their provider is answering all of their questions about a treatment option, that they would like to use resources like this more often in their sickle cell care. And notably, nearly all of our sample endorsed that after using the toolkit with their provider, they felt more informed, more involved in their care, and more confident and prepared to make decisions. We haven't run inferential statistics just yet because, again, we're still recruiting, but about 50% of our sample is showing improvement in disease and treatment knowledge from before to after using the toolkit, and our shared decision-making questionnaire is showing pretty good scores for kind of feelings that they were actively involved and part of the decision-making process. So our next steps are to complete the pilot trial, and that will give us essential preliminary data to then be able to apply for funding to test this in a larger multi-site clinical trial that's powered for efficacy. We also are really interested in expanding some of the toolkit resources to decisions about curative therapies. And we want to explore ways to disseminate and kind of expand the reach of these tools beyond Nemours. So those are some of our next steps. And I want to thank everyone who has contributed and supported this work, as well as our funding sources. And I'm happy to take any questions.